Every morning, some people wake up wondering, why do my joints hurt so much? This is a question many people with rheumatoid arthritis quietly ask themselves before they even step out of bed. For many, that pain traces back to rheumatoid arthritis, a systemic autoimmune disease, meaning the body's own immune system mistakenly attacks not only the joints, but can also affect the heart, lungs, kidneys, and other major organs too. In studying RA, we don't just focus on the symptoms. We analyze how treatment works, how lifestyle factors and family history shape recovery. We use SPSS to explore what shapes a patient's recovery. One key variable we focus on is HAQ improvement, the change we get by subtracting the score after treatment from the score before treatment. The larger the improvement, the more the patient regains mobility and daily function.
There are three treatments used to treat rheumatoid arthritis, which are methotrexate, biologics, and NSAIDs. Before doing the main treatment analysis, normality tests between HAQ improvement and treatment type were done. However, based on the p-value obtained, it was determined that the distribution is not normal. Since the distribution is not normal, non-parametric tests, which was Kruskal-Wallis tests, were done to analyze the most effective treatments. The results obtained suggest that the p-value is higher than 0.05. Means that there is no statistically difference in HAQ improvement among all three treatments. Normality tests were also done between RA duration and treatment type, and the results obtained suggest that the treatment groups are normally distributed. Results from the one-way ANOVA test showed that there are no statistically significant difference in mean disease durations among all types of treatment, as p-value is higher than 0.05. Moreover, from the post-hoc test, it can be seen that all treatment pairs have significant value more than 0.05. This determines that all pairwise treatment does not have a statistically significant difference. The results suggest that the type of treatment used was not influenced by the duration of rheumatoid arthritis disease.
Based on the test of normality between disease activity score and racial classification, all groups showed p-value of greater than 0.05. Hence, this indicates that the data are normally distributed. Moving on to the test of normality between disease activity score and BMI category, it also shows that the p-value category 3 and 4, which is overweight and obese respectively, are greater than 0.05. The f-value was 5.816, which indicates that the variation between the BMI group is larger than the variation within the groups. This strengthens the conclusion that BMI category has an impact on the disease activity score. F-value for this test was 1.433, which is relatively low. This indicates that the variation within each racial group is much larger than the variation between the groups. In other words, the groups overlap too much to be considered different. Therefore, in this sample, race does not appear to influence disease activity.
A normality test was done to see if the data of HAQ improvement in patients with and without comorbidities are normally distributed. Both of these values are less than 0.05, hence it is not normally distributed. However, for patients who smoke, it is not normally distributed, while patients who don't smoke is. Similarly to smoking status, patients who consume alcohol is normally distributed, while patients who do not consume alcohol is not normally distributed. Ultimately, the non-parametric test Mann-Whitney U was conducted as it is more robust and does not require the normality assumption. The results suggest that the p-value is more than 0.05. Thus, the null hypothesis failed to be rejected. This means that there is no statistically significant difference between a patient with and without comorbidities when it comes to HAQ improvement. The results suggest that the p-value is more than 0.05. Thus, the null hypothesis failed to be rejected. This means that there was no statistically significant difference between a patient who smokes and don't smoke when it comes to HAQ improvement. The results suggest that the p-value is more than 0.05. Thus, the null hypothesis failed to be rejected. This means that there was no statistically significant difference between a patient who do and don't consume alcohol when it comes to HAQ improvement.
When I look at the data, I expected patients with a family history of RA to recover differently, maybe slower, but when I run the Man-Whitney test, both groups, those with family history and those without, show almost the same level of improvement in their HAQ scores. The difference was tiny and statistically it wasn't significant at all. This means that in our dataset, genetics didn't shape the recovery but the treatment did.
For the next part of our analysis, we look at how different treatments were related to side effects and dosage patterns among the patients. First, the chi-square test showed a significant association between treatment type and side effects. In other words, different treatments tended to produce different reactions. Then we examine whether treatment dosage changed based on disease severity. The result was not significant, meaning patients with mild, moderate, or severe disease received similar dosage levels. This suggests clinicians may follow standardized dosing guidelines. However, when dosage was compared with treatment type, the difference became very clear. Methotrexate was prescribed weekly, biologics was spaced every 2 to 4 weeks, and NSAIDs were taken as needed. Overall, both side effects and dosage patterns depended much more on the treatment used rather than how severe the disease was. These findings also suggest that the effectiveness of each drug relies on using the correct dosing schedule for the treatment type rather than increasing the dosage based on disease severity. Based on this, sticking to the standard dosing appears appropriate as higher doses did not show additional benefit.